Thank you so much for inviting me. And the usual caveats go. I'm linked to a dongle thing, which hopefully will remain and give me enough bandwidth to talk to you, and with all the caveats that I hope you can hear me and see me. So, yeah, I mean, what a celebration for you. And I have just been asked to talk really about, I mean, the title is Let's Build a Future as Good as My Past, and to fit in with your 10th anniversary, just to look back a bit. Now, sometimes there's nothing worse than somebody looking back and telling everybody it was all perfect in the old days, and we tend to have the habit of wearing rose-coloured spectacles, but I hope I'm not, and if you just bear with me. So just the other day, I was asked, would I choose general practice again? Despite all the issues that are going on, would I choose it? Would I choose medicine again? But in particular, would I choose general practice? And they asked me specifically now because I had been whining a bit, if that's the word, about having more complaints in the last 2 years than in the last 40 years. And I qualified over 40 years ago, and that's absolutely true. And I suspect everybody listening to this. So I was in a sort of slightly demoralized state at the time, but I reflected for a moment, just a moment, and I actually said there would be absolutely no doubt in my mind that given everything I know now, not just reaching the president or the chair of my profession, but everything I know now, warts and all, I would choose medicine again 100 times, and I would certainly choose general practice again. And I was thinking, why? Why would I choose it again? And it isn't for the accolades. It isn't because, as I said, I'm chair and president. It isn't even for the financial security that it gives. There are many jobs that give probably, one would argue, better financial security. It isn't even because of the flexibility. One could argue that general practice is actually the most flexible of all careers. But when I reflected on it, it's because of those wonderful moments in the consulting room. Now, I hope that doesn't sound too naff or too romantic, but it is those wonderful moments in the consulting room where there is just me and my skills and my patient and their needs. And in that transitional space between me and that patient, that's where the magic of healing takes place. And if you're a GP, and if the world isn't as frenetic as it is at the moment, then you tend to have the time and the space for that magic to happen. And when it happens, as with me, and I calculated I've probably done 100,000 consultations over the last 30 years, that is an awful lot of people that pass your way, an awful lot of interactions that you don't need any thanks, you don't need blazoned on billboards to know that one has done a good job. You just need the feeling when that patient leaves the consulting room that you have made a difference to their lives. And over the last 30 years, I fundamentally feel that in the consulting room, I have made a difference to people's lives that I couldn't have done in any other professional capacity, in any other role. So that's why I would choose medicine. But before I get too romantic, what I feel is happening now is that space, that interface, that transitional space has been interfered with. It's being corrupted in a way, and it's being corrupted by the systems that we're working with, by the workload. It's being corrupted by the professional freedoms, and it's being corrupted by what I call the monetization of healthcare, the movement of healthcare from something that was that's around people and caring into something that's become much more of a transactional relationship. So there is a lot that is at risk in interfering with that space, and if we're not careful, then it will be eroded even more, and medicine will become a transactional profession, not one where there is that transitional space and the magic of healing. Now, when I was reflecting again of what to say, I feel that we had more of the future than 15 years ago. We had more of the protection of that space than we do now. And let me explain a little bit, because if people listening to this are going to build a future, then we have to, a better future, then we have to learn from the past. And the NHS, of course, is it's under stress at the moment, but then so too are all healthcare systems. So I think we shouldn't over egg the risks of the health service. I think many are. But let me just reflect with you about building on the future. So what we've got to do, and what people in authority and power have to do, is they have to dismantle the systems which are prohibiting us from doing what we should be doing as healthcare workers, which, as I said, is that moment in the consulting room. They must be, the people in power and authority must put systems in place to actually create a modern health service, a health service that allows us to do that, but within a modern system. And again, when I was reflecting what to say, the systems must be put in place to stop the separation between care in the community and care in hospital practice. And these systems were put in place many, many years ago. In fact, they were probably put in place 200 to 300 years ago, when, after the Great Plague, oddly enough, when GPs weren't called GPs, of course, but when the generalist community practitioner first emerged. And if we're going to create a better future, and again, built on, I hope, not the rose-coloured spectacles of my past, then we have to create new ways of working that allows us, and to use a phrase that was actually created by the Royal College of Physicians, but we have to create teams without walls. We have to stop this artificial boundary that happens at the front door of the GP surgery or the front door of the hospital, and actually create much more fluid systems so we all look after our populations, us primary care and community care, and in hospitals looking after the patients just in their four walls. And if we're going to do that, if we're going to break down those metaphorical and real boundaries, then we have to find new ways of working. We have to find new ways of training practitioners so that we actually have common stems, so that we actually move hospital practitioners into the community, not as supporting GPs, but learning what it's like to deliver community care. We have to make sure, and just by the by, every single GP has worked in hospital. Very few hospital practitioners have worked in general practice. But what we have to do going forward is to make sure that we capitalise on doctors and nurses working in community settings. We have to change the financial incentives so that we don't inadvertently promote and create perverse incentives for episodic care, but we've got to create incentives for community care and for continuity of care. And we've also got to change the way that we work within systems. We've got to start creating teams that, as I said, work across those boundaries, that start delivering care across that transition between hospital and community services. And if we do that, then I think we'll be able to create a health service that's fit for the future. Now, when I say I had more of that 15 years ago, that's absolutely true. So when we say that it can't be done because the money isn't right, we don't have the training, we don't have the buildings, we don't have the space. 15 years ago, we had about 40 to 50 ancillary staff attached to our surgery. Now, they weren't all employed by us, but some were, some weren't. But we had anybody from the community beat officer to the diabetic consultant, to the community midwives, to the employment support worker, to the elderly care CPN, attached to us in some way or another. We also had services that we now call in-reach. We didn't call them in-reach services then, we just called them delivering care inside hospitals by community workers. So I would do ward rounds or attend ward rounds with my hospital consultants, and we would also have hospital consultants attending our practice and our community mental health teams to help deliver care across that transition. And we also had intermediate care hospitals, low threshold hospitals, where we could admit patients, even if they were just off their feet, we could admit them for a few days to try and sort them out. And believe it or not, we could even admit them with their pets, as long as their pets could be confined to a single room. So these things can be done, but I think they rely on a commitment to bring about change, which I know that you're doing in the area that you work, because I know there's an awful lot of change and an awful lot of innovation that's happening in that area. So when I look back, hopefully I'm not looking back with rose-coloured spectacles, because things weren't all good. In my day, of course they weren't. We had very poor quality systems, very poor data systems, and we would expect patients to basically take a half a day off work in order to spend 5 minutes in our consulting room. But equally, we had a lot of practices and procedures that worked for our patients, that worked for our community, and that also worked for our hospital practitioners and our hospital system. And unless we build on those and recreate those, I'm afraid the divisions between us all are going to grow further and further. And fundamentally, going back to where I started, there will be less time for that magic space within the consulting room, where I think that the essence of being a doctor happens, which is the essence of the consultation. So I just wanted to share those thoughts with you and open it up for questions or thoughts in this artificial space of delivering talks via the internet, which is always very odd. So Abid, I thought I'd stop there and see if there's any thoughts or comments.
Thank you very much, Claire. That's really, I was hoping that your talk, Building a Better Future, would give us some blueprint as well, how we could go about it. I think in terms of the changes in NHS now, particularly ICS and provider collaboratives and working with GPs, is an opportunity to change things. Any thoughts on that? Could we return back where to the point where your practice had so many people from other organizations working with you?
ICSs are a good place to start, but if we wait for ICSs to deliver the future based on my past, I suspect we'll be here. We'll never get any change. The change starts with a commitment, with a will. The changes will start with people identifying a need. So, for example, the need to deliver better care to the frail elderly, the need to deliver better continuity of care when patients are discharged from hospital. So it will be around like-minded people identifying a need and then determining how to deal with that need. So let me give you an example, Abid. When I was head of NHS London primary care looking at transformation, we developed some standards around what GP should be delivering around continuity of care, what we call proactive care, and access. And the one standard we could never find any metrics towards was that of transitional care, integrated care, so care across the primary and secondary care divide. And because it's very difficult to find a standard, but I was been thinking about this, and I've been thinking about it now for quite a while, and I think there is a standard. And I think if we set a standard around what I call a week, a month, a year, forever, if you like. So if we started delivering, if a hospital, for example, started to work out a system to deliver continuity of care across the transition for every patient that, say, had a minor procedure, for a week after a week of that procedure, for a month after some sort of major diagnosis, for a year after a catastrophic diagnosis, and for forever for a terminal diagnosis. Now, how that would be delivered, of course, then depends on the systems within the organisation. So it might be a 24-hour telephone helpline. At the extreme end, which is catastrophic diagnosis, it might be the creation of a multidisciplinary team involving, of course, GPs and community services. But if we started to set a standard and to say, well, let's look at the standard rather than what happens now, which is a patient's admitted for any procedure, for example, and then has a problem, say a wound infection, and we have to go round and round the houses to get them seen. Usually they have to go back via casualty. But if we started to think differently and to think of ourselves as one system, rather than two completely different systems, then I think we'll start improving the care that we provide for patients. But I also think, Abid, we'll start making the staff happier, because the other role I have, of course, is caring for the mental health of staff. And at the moment, nobody is particularly in a good place. And I think what many of us are missing is around continuity, is around team working, and is around delivering care that just isn't so transactional.
I think, Claire, one of the things that we come across, and I meet GPs really quite often, and when it is difficult to get them engaged, sometimes, not all GPs, I have hastened to add, is that they feel they are overwhelmed at the minute. And the overwhelmed feeling is that there's so much that they have to carry, particularly risk or services, that they don't have space to think or get engaged in new shaping the service for tomorrow. Do you see that pressure on GPs going forward easing at all?
Well, the first thing is GPs have shaped tomorrow's future far more than any other professional group. And I'm not saying that just because I am a GP, but we've, for example, 25% of acute trusts don't have the ability to do electronic prescribing. We have, I think there isn't a single practice now that wouldn't be able to do electronic prescribing to a pharmacy of their choice. So GPs have always shaped the future. The problem there is, and again, I've thought about this, there's about 100 different specialties and subspecialties in secondary care, and there's only one GP specialty. Now, of a GP specialty, we're covering that 100-odd specialties and subspecialties within a single person, within 10 minutes. So, and what also is happening is that we're now victims of our own success. So I do more now than 2 more patients to a greater degree of complexity than any other GP in the world. We have, so for example, a German GP would never prescribe a second or third generation anti-diabetic, whereas we will now initiate insulin onto patients. And I think what we've done, to be absolutely honest, is we've taken on more and more. We've flexed and adapted and learnt, and now we're full. And so when you say it's difficult to engage us, we don't have the time to be engaged. And every minute that we're not in the consulting room, somebody has to pay for that minute. And again, I think hospital doctors and I adore hospital doctors, my husband's one, but they have the privilege or the security of not having to lose income if they step outside their consulting room, whereas GPs will lose income if they're not in their consulting room. So the way to engage us is actually to maybe not send us the work that can be done by your own teams, and actually to look at a bit like Sky, and they were trying to make the British cycling team the best in the world, tiny little incremental changes. How can I take the pressure off my GP colleagues? For example, only a 1-page summary rather than 2. If you 2 doubles the time for scanning. Doing your own medication reviews, not listing or putting a list saying what's changed since the last time, not just listing everything again, so we have to double check. Not having a box that says GP to do, which means that it sort of pushes you into think, well, what can I get the GP to do? So if everybody, and we can do the same in our own practices, and how we can help you, but if everybody listened to this, just thought, what are the 10 little things I can do that will take the pressure, then I think we'll all be in a better place.
Thank you. I'm just checking for any questions from the audience. I checked a couple of minutes ago. There wasn't any at that point.
Well, that's good then.
Still no question. So Claire, I think, you know, one of the things that is attractive about general practice is that some of the female graduates are choosing that as a specialty going forward. And I say this because some doctors that I know have preferred general practice as a career going forward rather than hospital care. Why do you think is that, if it is so pressurized that Do you see that as a change going forward?
Yes and no, of course. I mean, women are becoming the majority of doctors. I mean, look at the registrations. When I started, and probably when you started, only 1 in 10 of my medical school intake were women, and that was in a medical school that promoted women and actually actively encouraged women to join. So it was probably about 5%. Now, general practice has always been a flexible career. Has always been one that that allows you to have a work-life balance theoretically, but allows you to mix family life with work. So it always has. It's always been very flexible. But I think behind your question, to be honest, is this misconstrued idea that general practice is full of part-time people. We have the problem in general practice is that we define ourselves by the number of sessions we do, whereas everybody else defines themselves by their PAs. So there are very, very few part-time doctors, GPs. It's just they don't include all the other bits that they do, which makes up their job. And we then have this other term, which is called portfolio careers, which is not a very I don't know what it means. It basically means you mix and match. Whereas a hospital doctor who might do appraisals and might do some clinical work and might do medical legal work will never call themselves portfolio. And then there's the other issue, which is that a part-time GP is probably 37.5 hours, which in anybody's mind is a full-time person. So I think we don't do ourselves a disservice. We do ourselves a disservice by these labels. But medicine is a de facto, or general practice is de facto a much easier job to fit in if you are wanting to be part-time. But I think we also have to be mindful there are many, many other specialties that have preponderance of women. Pediatrics is preponderantly women. Psychiatry is preponderantly women. Surgery is increasingly women, though still it's preponderantly men. So I think we need to be careful of just stereotyping that general practice is the soft option. It certainly isn't, and it's one that women go into because they want to do that. But saying that, it is a good specialty if you want to take gaps, and if you want to, as I said, I mean, I've had 2 children. It is one that you can tend to work around your family life, though not as easily now as you used to be able to.
There's a question, but it is marked anonymous, so I better read it as it is because it is a difficult question. There is an enormous variability in how general practice is delivered. How do we ensure better standards such as continuity of care? And a second part of the question is the independent contractor status sustainable?
Okay, well, the first question is really 2 questions because continuity of care is not to do with quality, it's to do with the numbers of GPs. And I keep saying there was 200% increase in hospital consultants over the last decade or so versus a flat line for general practice with the increased workload. So we are not miracle workers. We've just, we can't feed the 5,000. We're not miracle workers. We cannot deliver what essentially is 3 plane loads of jumbo jets with only 1 pilot. So, and the quality of general practice is actually, I mean, there's variable of quality in every specialty. So I think it's easier for people to notice it in general practice because everybody has a contact with a GP. It's much harder to notice it, for example, in rheumatology. So I might, in my professional life, only interact with 1 rheumatologist in 20 or 30 years, whereas every single patient and every clinician interacts with tens of GPs. So it's much easier to spot it. With respect to continuity, yes, the holy grail of my profession is continuity, but I can't deliver continuity of care if I'm at the same time doing somebody else's work. And increasingly, this is what's happening with general practice. We're doing other people's work. So if people listening to this want a better general practice, as I said before, it's up to each and every one of us to incrementally look at how you can reduce our workload. And it's very simple things, as I said, 1 page summary, not 5 pages. putting the key bits right at the start, not having a box that says GP to do your own prescribing, to ask for your own follow-ups of your blood test, not expecting it. Now, with respect to the independent contractor status, for those of you that aren't GPs are paid in a very odd way. So whereas hospital doctors get a salary, our salary, in a sense, is filtered through as a small business. So whatever's left at the end, we pay ourselves. Whatever's left after paying our staff and paying the light bills and the electricity bills. But our income is we're not allowed to go out and get additional income. We're 90% of our income has to come from the NHS. We're not really independent in that we can't sell goodwill, we can't hold shares, etc. But it is this strange conundrum that was set up in 1948. Now, I have changed my view on this over and over again, and I'm a large partnership, and about 15, 20 years ago, I thought, well, what's the point of the independent contractor status? Because I don't earn any more money unless I make savings. I can't make savings because, unless I don't use a colour photocopier. But actually, I think the value of the independent contractor status, the real value, has been the ability to innovate and the ability to bring about change, not within a bureaucratic structure. And I think we need that more than ever now. We need to be able to flex. We need to be able to change, and we need to be able to deliver very good care for patients. And if the independent contractor status and the leadership it allows us to do, then I think that's important. But those of you who don't understand ICS, it's more complex than that, because we also tend to hold the lease on our premises. So, for example, I'll give you a little example. The government has said that everybody's getting a 2 or 3% pay rise. Well, if our uplift in general practice is only a 1%, that means we take a 2% pay cut. I think hospital doctors would be shocked to know that if all of your staff got a pay rise, it means you get a pay cut. So there are real tensions within the independent contractor status. But as I said, I've changed my view over the years, and I think on balance now, the partnership model allows us to flex and innovate in times of trouble as well as in times of plenty, and will deliver a far better care for patients.
Claire, there's another question. This is from Jane Greening. She's our head of School of Psychiatry in West Midlands. And she's asking, would you ask Claire to say something more about experiencing managing the services for sick doctors and the potential need for what may need to change to manage doctors' well-being going forward?
Yeah, of course. I mean, and it's not just doctors, it's all staff. So I've been running a service for mentally ill doctors and dentists now for 15 years. I've just committed running it last month. And we've had about 17,000 doctors, mainly doctors, coming through, about 10% of dentists. And what have I learned about all of this? I've learned you can't have burnout unless there's a burning platform. So burnout is an occupational disease akin to trigger finger if you use a vibration tool, or mesothelioma if you're down in the mines. And no public health specialist would ever say, if you're at risk of trigger finger, we'll just do some more vibration. Or if you're at risk of, of getting cancer down the mine, well, let's put more asbestos down there. What we have to do is to put the fire out. And that boils down really to addressing the real issue around burnout, which is intensity of workload. So we can support our trainees and our doctors and our nurses, and we can provide them with outlets, and we can provide them with all the support that we think is appropriate, and we can provide them with safe spaces to talk about the emotional impact of their work. But if we're going to put them back into spaces where they're unable to deliver the care they are trained to deliver, then we're going to get mental illness. And examples that I hear of an FY2 who was put in charge of a whole respiratory ward. Now, that would make anybody anxious. And if we continue to do that, then the levels of stress amongst the staff that we're putting are never going to be taken away by resilience training or donuts at lunchtime. What we have to do is to put in what we know works, which is supervision, space talk about the emotional impact, reduce the intensity of the workload, and proper team working. So I'm not sure that answers, but if I talk a bit more about practitioner health, the real joy about practitioner health is if you build it, they will come. And when we had our very first patients, I can remember thinking nobody will come to this service, nobody, they'll all be far too embarrassed to come. In fact, the very first patient that came over was a really complex doctor with severe ADHD, and after that they came in droves. And during the pandemic, any of you that have been following my writings, over the pandemic we've had 100% more doctors predominantly presenting to our service than pre-pandemic, and it's still not back to pre-pandemic levels. And the overwhelming problems presenting have been anxiety. And again, I suspect many of you listening to this will resonate with that. Anxiety about loss of certainty, fear, bereavement, and just free-floating anxiety about the existential threat that many people felt during the pandemic.
There's a comment someone has put on the chat, on the question section. They want to express appreciation and gratitude for GP colleagues for the skills and ability to deal with pressures they're under. So there is recognition that GPs are under tremendous amount of pressure. And I take this point very seriously, that wherever we can do some support to help them or reduce their workload, we need to explore that.
Well, I think that's right, because it's not just for us you're doing it, it's for our patients and for yourselves. Now, we do want support, but we want more than that at the moment. We want every single health professional. You see, what the other problem is the expansion of the workforce in hospitals. So, for example, you've got nurse practitioners, physician associates, all sorts of people writing to us to ask us to do things. And as I said, there's more than 100 specialties and subspecialties and only one GP specialty. So each one of you, you're probably a member of about 5 or 10 in your team. So that's 10 times 100. Each one of you writing to us to ask us to do things. Now, this never was in the past. This never, ever happened in the past. We were never in the past asked to follow up our hospital doctors' blood tests. That would be the hospital doctors needing to do that. We would never be asked even to monitor cytotoxic treatment now that we're being asked to do. We'd never be asked. Sometimes I'm asked to prescribe drugs I can't even spell or pronounce, and I won't do it, but I'm experienced enough to say, listen, if I can't even pronounce this drug, how on earth am I meant to know what I'm monitoring? So every single one of us needs to look at each other's work, because we're all one profession, one team, one NHS. And just to start to say, is this necessary? Even asking, the classic letters are patients being seen in your department, and then you ask them to come to us for us to arrange a follow-up appointment. Well, all of that is a lot of work, and also means if they don't come to see us, we have to chase them, rather than give them a telephone number to ring up and make their own appointment. So these are things that I think every hospital, and if we wait to ICSs, then I'm afraid it will never happen. We've got to do it before ICSs.